Good morning, and I'd just like to thank the organizing committee for the opportunity to present. This should be a very interesting symposium with some real experts. I've been charged with the topic of preoperative and intraductal assessment, or intraoperative assessment of bile duct anatomy. And again, I think clearly for anybody that operates in the right upper quadrant, we need to understand the importance of the biliary anatomy. I think a sound grasp of the anatomy is of utmost importance in preventing bile duct injuries from occurring. It's also necessary for each specific patient to understand their individual anatomy in order to determine appropriate therapy if a bile duct injury occurs, whether that best will be managed endoscopically, percutaneously, or operatively, and then it's of utmost importance in our operative planning in the management of these patients. Again, I'm going to do some basic anatomical things, which again I think will be reviewed for everybody in the audience, but I think they're very important and concepts that we'll need to highlight. Again, when we think about the biliary anatomy, I think we need to understand it in all aspects, including the intrahepatic bile ducts, the extrahepatic bile ducts, the gallbladder, the cystic duct, and what goes on in the sphincter of Oddi as well. As we all know, the biliary anatomy is extremely variable, and I think we're all obligated to know the major variations, and we'll just go through these briefly here. So again, the vast majority of patients, somewhere between 60 to 70% of patients, will have classic biliary anatomy, where the right anterior and posterior ducts will come together to form the right hepatic duct, and they will join the left hepatic duct as a bifurcation. In about 15% of patients will see a trifurcation where the right anterior and right posterior ducts will join the left duct, causing a trifurcation. Another common variant is the right posterior duct. That seems to be the most variable duct as it comes into the hilum. In about 8 to 20% of patients, you'll see the right posterior duct loop behind the right anterior duct and join actually the left hepatic duct. In about 5% of patients, you may see a low insertion of the right posterior duct, which can become important in cholecystectomy, as well as the development of bismuth-5 type injuries in patients undergoing cholecystectomy. Again, in slide E here, we see this anomaly here occurs about 6% of the time. We have the right posterior duct coming higher up into the left hepatic duct, and again, important in reconstruction and understanding that anatomy in injuries. 2% of patients will have multiple segmental branches coming into the left hepatic duct. And this could also be very difficult to deal with at this time. And the last figure shows, again, the right posterior duct coming in almost at with the cystic duct, almost causing a trifurcation, again, which can be quite hazardous. Again, the arterial supply to the extrahepatic bile duct is very important, and Dr. Strasberg and Dr. Helton back in 2011 published a wonderful review of vasculobiliary injuries, which I recommend highly to everybody in the audience with this, and these figures are taken right from that paper. But again, the arterial supply to the extrahepatic bile duct really comes in three levels or orders of arteries. The common hepatic artery coming off of the celiac axis, giving off the right gastric artery and the gastroduodenal artery branches, and then bifurcating into the right hepatic artery going into the anterior and posterior branches, as well as the left hepatic artery going into the segmental branches here. And then the cystic artery traditionally will come off of the right hepatic artery on the right side of the bile duct. The actual arterial supply to the extrahepatic bile duct comes from these marginal arteries, the 3 and 9 o'clock arteries, which are come off of the major hepatic artery branches, and then this transverse hilar marginal artery, which is also very important in potential collateral crossflow from the right and left systems. And then the final order is really the epicholedochal plexus, where these branching points from the marginal arteries go actually into the bile duct. And again, I'm sure some of our other discussants will talk about the vascular complications and injuries to the bile duct and its implications towards repair. So it's very important to understand this anatomy. Again, in preventing the injuries, you also need to understand cystic duct variations. Again, this slide shows some of the more common ones. I think we all need to be aware of the very long cystic duct with a low insertion into the distal common bile duct, sometimes intrapancreatic. This can be very easily mistaken for the common bile duct there. You can also get a high fusion of the cystic duct with the common bile duct almost at the bifurcation. Again, we can have accessory hepatic ducts that come in near the insertion of the cystic duct. And slide D here, we see the cystic duct draining directly into the right hepatic duct here. And then we also have these cholecystohepatic ducts that drain right directly from the right lobe of the liver into the gallbladder, which can be very important in bile duct injuries. Again, along with the, there still are some variations in the cystic artery anatomy, although not quite as prevalent as we see with the biliary anatomy. Again, classically, the cystic artery will come off of the right hepatic artery. You can also get a long cystic artery coming off of the gastroduodenal artery. Very rarely, you can have a double cystic artery coming off of the gastroduodenal artery as well as the right hepatic artery. Again, off the proper hepatic artery there. So again, I think very important to be aware of the variations in the cystic artery anatomy as well. And again, a whole cadre of gallbladder formation anomalies. Again, these are not as relevant to biliary injury as they usually stay out of the hepatocystic triangle. But again, I think just to be aware of the pharyngean cap, bilobed gallbladder, gallbladder diverticulum, hourglass gallbladders, and septated gallbladders. Again, they can be presentations for biliary disease, but they tend not to cause significant difficulties with understanding the anatomy, at least when it comes to operative anatomy. When it comes to imaging, biliary imaging in terms of bile duct injury, I think we use it in two ways. The first is really the prevention of biliary injuries and understanding our anatomy prior to going to the operating room. And then the second factor is actually using it to help us plan with our therapeutic options and treatments for bile duct injuries. And again, I think when I think about these, I think about them as non-invasive. So, percutaneous ultrasound, the workhorse now MRI, MRCP in the preoperative setting, again for injuries and diagnosis, ERCP and transhepatic cholangiography, and then intraoperatively both cholangiography and ultrasonography, and we'll touch briefly on each one of these with the exception of the ultrasound. So again, I think MRCP is clearly our workhorse in the management of diagnostic imaging of the biliary tree at this point in most institutions. Again, it is very institution dependent in terms of the quality of the MRCPs and the dedication of your radiologist to the quality of the images that you can get. But again, I think it's clearly a non-invasive technique to evaluate the biliary tree. It defines our biliary anatomy, and it's very important in the diagnosis of benign and malignant biliary diseases, including common duct stones, benign strictures, and malignancies. And again, you can see this is what we call an MIP, so an enhanced image. Gives very excellent detail of the biliary tree and the pancreatic duct. Here again, these are again some examples of the common variations that we'll see here. Again, a hepatic trifurcation. You can clearly see the right anterior, posterior, and left ducts coming together as a trifurcation. Again, very helpful if your patient has an MRCP beforehand to actually look at it before you go to the operating room, even if you're just doing a simple cholecystectomy, because again, you can get a sense for a low insertion of a right posterior duct, which could potentially be trouble for us in the operating room. Here you can see a right posterior duct joining the left hepatic duct. Here, a right anterior duct actually joining the cystic duct before it comes into the gallbladder. And again, the low insertion of the cystic duct or the determination of common bile duct stone. So again, a lot of information can be get from a high-quality MRCP from a diagnostic purpose. Again, I think ERCP becomes our workhorse in the diagnosis and treatment of common bile duct stones, as we all know, as well as the identification and treatment of minor bile duct injuries and leaks with stenting. And again, here you can see a patient with a cystic duct leak. It's got a percutaneous drain in here to control the biloma, and eventually underwent endoscopic stenting and resolution of the bile leak several weeks later. Again, I think one of the caveats of ERCP and bile duct injury, again, is that its inability to demonstrate the proximal anatomy, which is the most important for us in terms of planning major bile duct injury repairs. Again, you can see an ERCP that shows the distal duct nicely with several clips, and then no proximal anatomy, which is the most important for us. The other thing that you also need to be aware of is that you need to be able to interpret the ERCP images appropriately. Again, in this patient where you think you potentially have a bifurcation, left and right ducts, clearly the patient with a persistent bile leak, you can see on an MRCP a isolated right posterior segment, which was missed on the ERCP. So again, I think that combination of the tests are very important in our diagnosis and management. Again, percutaneous transhepatic cholangiography. Again, it's very important in defining the proximal biliary anatomy for us. Again, the ability to control bile leaks, to treat biliary strictures, both primary and secondary strictures, as well as for the removal of intrahepatic stones and bile duct stones with a combination of percutaneous cholangioscopy and lithotripsy and lasers here. And again, here you can see another example of a PTC with a bile duct injury of a dilated bile duct with a trifurcation, a transhepatic wire being placed across, and then a transhepatic biliary stent in order to define the proximal anatomy so you can plan your repair. I think in terms of our intraoperative biliary imaging, again, I think it breaks down into three real categories: contrast cholangiography, our standard intraoperative cholangiogram, intraoperative ultrasonography, and probably the new player on the block is this fluorescence cholangiography in select institutions, and several papers are actually in press with this as a potential way. Again, I think intraoperative cholangiography, again, there are several disadvantages that people that are not fans of it will quote. You know, a percentage of patients you'll be unable to cannulate the cystic duct either to a friable, inflamed cystic duct in the setting of acute cholecystitis. There's potential for increased operative time, and most importantly, you can still have an injury with an intraoperative cholangiogram if you don't interpret it correctly. And I think that experience in interpreting the cholangiograms is also very important. And it does require dissection of the in the triangle of Clow and has potential for causing a biliary injury, but hopefully it will be recognized in that case. I think clearly the advantages are the anatomical detail, the potential to identify common bile duct stones and strictures, and there is some evidence that it may decrease the rate of bile duct injury, and I'll show one of those studies in a second. Again, I think the interpretation of intraoperative cholangiography is very important. You must see contrast in the duodenum. It's important to visualize all of the intrahepatic ducts. You can also examine it for filling defects in the ducts, and based on the size of the common bile duct and cystic duct can determine your approach to common duct stones. And again, here, the upper picture represents an adequate cholangiogram where you see contrast in the duodenum, all of the extrahepatic bile duct, the cystic duct, and the right anterior, posterior, and left bile ducts. I think you feel pretty comfortable in this situation that you're going to be okay. Whereas the lower cholangiogram is an inadequate cholangiogram where we only see filling of the distal bile duct and no intrahepatic filling. When you see this, you have to be worried that you have a major bile duct injury or the potential for a major bile duct injury, and that needs to be sorted out. Again, this is a forest plot from a meta-analysis looking at population database studies greater than 10,000 patients, trying to ask the question whether or not the performance of a routine intraoperative cholangiogram decreases the risk of bile duct injury. Well, there's no good comparative prospective trials with this because of the low incidence of bile duct injuries. This is the best data that we have that suggests that the performance of a routine intraoperative cholangiogram may decrease the risk of a bile duct injury with an odds ratio of 0.67%. So strong evidence to suggest that it probably is a reasonable thing to put into practice. Again, intraoperative ultrasonography, again, allows laparoscopic ultrasonography at the time of laparoscopic cholecystectomy. It requires scanning in both the transverse and longitudinal planes, requires no dissection in the porta hepatis, and can accurately identify in greater than 90% of the cases the common bile duct, the hepatic duct bifurcation, cystic duct and common bile duct junction, and as well as information about the hepatic artery and the portal venous branching. It also is very sensitive for the identification of common bile duct stones. Again, no good head-to-head studies looking at its role in preventing bile duct injuries. This was a single institution experience in a retrospective review where they had a bile duct injury rate of 1.8% in almost 600 laparoscopic cholecystectomies when they did not use routine intraoperative ultrasound, whereas when they applied intraoperative ultrasound routinely, they had no bile duct injuries and 0%. So I think you can make an argument for the use of that as well. The newest thing is this fluorescent cholangiography. So this technique does require special equipment in terms of a xenon light source, special lenses that allows infrared transmission of light, and a control unit. The estimated cost of this is probably about $60,000 for the equipment to do this, but then you can apply it to your patients. But the technique involves administration of a milliliter or 2.5 milligrams of indocyanine green, which is given on induction of general anesthesia. And then you can see by flicking on the light source that you can get a representation of the common bile duct and the cystic duct here. Here's the picture before the dissection of the triangular collo. After the dissection of the triangular collo, you can see the common bile duct and the cystic duct anatomy clear, and then you can see it anteriorly and posteriorly here. And this may help us aid in the visualization of the critical structures. Again, you can also pick up accessory bile ducts here. Here you can see, again, the cystic duct. This is an accessory bile duct or right posterior duct coming in low near the cystic duct, and you can see that confirmed on the MRCP preoperatively here. Ishizawa and colleagues from Japan, really, this is the only large study that's in the literature using this technique. Again, in this case, what they did was 52 consecutive patients where they used this technique during a routine laparoscopic cholecystectomy. And then their control was a intraoperative drip cholangiography for these patients. And so you can see before a dissection of the triangular collo, they were able to identify the cystic duct in 100% of patients, the common hepatic duct in 96% of patients, the cystic duct, hepatic duct junction in 96% of patients, hepatic duct bifurcation in 40% of patients, and the accessory hepatic ducts in the 8 patients that had them in a quarter of the patients. After the dissection of the triangle collo, they were able to identify the cystic duct 100%, the common hepatic duct 100%, the cystic duct, hepatic duct junction 100%, the hepatic duct bifurcation 40%, and all of the accessory ducts were identified. Again, this compares very favorably to intraoperative drip cholangiography. So that may be something in the future. Again, I think inclusion, I think understanding of the biliary anatomy and its variations are important to avoiding biliary injury. And both non-invasive and invasive imaging techniques are valuable for the prevention and treatment of these biliary injuries.